Good afternoon, everyone. Welcome to this webinar on piloting digital health solutions in healthcare. These webinars are a joint initiative of the Health Cluster Portugal and the IT Health, herein represented by Vera Moura. And this is the last webinar of the spring series. So no worries, as we are already preparing the next season, the autumn series. And today we have a very busy agenda to talk about this topic. We'll start with Dr. Saket Shukla from Siemens Healthineers, who will bring the topic of the use of digital twins in healthcare. Then Dr. Carlos Parente will follow with the presentation of some of the partnerships of Siemens Healthineers in the field of healthcare in Portugal. We will also have Professor Mónica Oliveira from Técnico Lisbon, who will be presenting her work on operational research and decision support tools in healthcare. And finally, we'll have Luís Patrão from Uphill with a presentation of the company as a case study entitled Safety by Default, Connecting the Dots in Healthcare. So I would like to thank every of the speakers for being here today and accepting this invitation. And I would start with the first two presentations of this afternoon. But before that, just wanted to tell you that we'll have time for a brief discussion and questions from the audience in a kind of a roundtable in the end of this session. So if you have questions, just drop them in the Q&A box and we'll ask them to the speakers later on. Also, and as usual, the presentation slides and the recording of the session will be made available after the webinar. So if you want to receive the presentations, just request it in the survey that you'll receive in the end of the session. And also the recording will be available on the Health Cluster Portugal's YouTube channel. So moving to the first two interventions of this afternoon. The first one by Dr. Saket Shukla. Dr. Saket is the head of digital business for Southern Europe in Siemens Healthineers. His background is software engineering, but he has been working in several roles at the intersection of digital technologies and health since 2000. He will be talking about digital twins in healthcare, and also, and in his own words, he's coincidentally a father of two real-world twin boys. Then his presentation will be followed by a brief intervention by Dr. Carlos Parente. Carlos is a healthcare consultant and the scientific partnerships country manager at Siemens Healthineers, and he has worked as a deputy director for quality accreditation and certification in private healthcare organizations, and prior to that as a healthcare provider. His background is nursing, and he has a master's in business administration. So again, thank you so much for accepting this invitation. And I invite Saket to please start his presentation.
Thank you, Patricia. I hope all of you can hear me all right.
We can.
Fantastic. So then I will just share my desktop and just let me know when you see it. Do you all see my desktop all right?
Yes.
Fantastic. So Patricia, thank you so much. Hello to everybody in the call. It's my pleasure to be here. How can healthcare win with digital twins? What is a digital twin? What purpose is served by a digital twin? How concretely can a digital twin aid in better personalized care delivery? These are some of the topics I touch upon in the next 10 to 15 minutes. So let's start with what is this damn thing which is called a digital twin? In very simple terms, a digital twin is a virtual digital representation of a real world physical object or entity. So anything which exists today in the physical world around us can be represented in a virtual digital form so that you can interact with it. And that digital virtual representation of any physical object or entity is what we all call by the term a digital twin. So let's start with, why is a digital twin relevant? Why is everybody talking about it? Why is there so much noise about a digital twin technology, irrespective of the various domains, industries, and so on? So I take a more big picture view of things. Perhaps many amongst us have read the book, The 7 Habits of Highly Effective People. For those who haven't, this book is a great primer on how to improve personal effectiveness and impact. In it, its author Stephen Covey basically says all things are created twice. First in the mind, a mental conceptualization and visualization takes place, and a second physical, actual creation of any object takes place. He goes on to say that to be effective and successful, plan and visualize what you are going to do, what you're setting out to accomplish, and then go out and create it. So, long story short, everything is created twice, first in the mind, before it is created in the real physical world. It is also why, when building a house, even before a single brick is laid, the house is first virtually created in the mind of the architect. Then, in the second creation, the house takes shape physically. It can now be seen, it can be touched, it can be experienced in the real world. It's also why our icons and idols slow down, take a moment, take a deep breath, visualize, and prepare before they take a key decision or action, because they worked it out that failing to prepare is preparing to fail, just like Benjamin Franklin said it a long time ago. So, to get things right, when the stakes are high, a digital twin helps to prepare for these high stakes situations by simulating an environment that is identical to the real world, is fail safe. There is nothing that happens which comes back to hurt us if we fail in this virtual digital environment. It's conveniently adaptable to try out changing things. It is highly flexible and easily reversible. And such an environment and such a tool is very well suited for planning, analyzing, experimenting, preparing for situations or actions where the stakes are high. The cost of mistakes is very expensive. So, just to frame it, I'll pause here, and I'm just trying to frame it as to what is a digital twin and why and or which situations are digital twins helpful for each one of us. So I'll now go into the topic of how can digital twins be applied in healthcare, and there are numerous various examples and applications of the digital twin technology. And in the next few minutes, I would be just talking about a couple of them. So let's start with Hugo Rodrigo. He's 70 years old. He has a granddaughter in whom you see in the middle of the photograph. Her name is Liliana. She is the center of the world and universe for Hugo. For the past some weeks, he has been complaining of weakness. He's feeling a little dizzy, giddy. He's fainted twice in the recent past. He's experiencing shortness of breath, and he's got sporadically pain in the chest, or he feels bottled up. So there's a lot of pressure in the heart and the chest that he feels. His wife, Philippa, who you also see in this photograph, was really concerned, and finally managed to force him to see their doctor. Hugo went and saw the doctor, and he was diagnosed with arrhythmia. So it's for those of you who don't know what an arrhythmia is, in very simple layman terms, It's an irregular beating of the heart. And he's been advised to go through a therapy which is basically called as a cardiac resynchronization therapy, for short CRT. So, some very simple, basic information about the cardiac synchronization therapy, or CRT. What it basically involves is, it's a treatment for the irregular beating of the heart. What it basically means is you take a very small coin-sized pacemaker and implant it into the body of the patient. It monitors the heart rate and detects if there are any abnormal beating of the heart, or irregularities, as you may call it. And when it detects any of these irregularities, it basically emits an electrical impulse or an electrical shock, small amounts, to basically stimulate or trigger the heart and get it back into synchronization. So basic, very simple resynchronization technique. So this is Dr. Fernandez. He's a cardiologist, a cardiac surgeon at that, and he knows much more about CRT than these 3 bullet points that you see on this slide. He knows that in the United States of America alone, there are 150,000 patients who are treated with this therapy. He also knows that amongst these 150,000 patients who are administered this therapy, 1 in every 2 to 3 patients, so as much as 50,000 of these 150,000 patients who are treated with this therapy mechanism do not respond to CRT favorably, meaning it's not fatal, but there is no improvement to the condition of that patient compared to before administration of this therapy. So what he wants to do is he wants to assess the risk of non-response to the CRT. He wants to identify where in the chest should those electrodes, which are part of that pacemaker, be placed. He wants to ensure that when he is placing that CRT implant, it is guided optimally. And what he's asking is, what if he could create a digital twin of Hugo's real-world heart and use it to plan the CRT to ensure that Hugo is not one out of those 50,000 patients for whom this therapy may not yield the optimal desired results. So to create such a digital twin of the heart, what we could do is we could take all the information, medical data that is available for patients for Hugo and other such patients. What it basically involves is taking any of the images, be it MR or CT or ultrasound, which basically tells us about the anatomy of Hugo's heart. We pick up the electrophysiology from the ECG documents and the graphs, or the catheter information which is available. We apply the biomechanics using the images and MR elastography images. We get the circulation, the flow, the pressure inside the heart and the veins and the arteries using ultrasound and Doppler. And if we combine all of this, and if we went a step further, we actually even take up the molecular diagnostics information or gene and genomic information of Hugo if it was available, and then basically combine it. And we combine it to basically visualize Hugo's heart in digital format, just as if it was beating inside his body. So the digital twin would give us not only the statistical information, but also the anatomy, physiology, and the biomechanics of Hugo's heart. It has similar dimensions to his heart, has the same electrical signal activity, same muscle contraction, the same pressure dynamics. So you're just basically simulating Hugo's heart in a digital medium. And imagine this model, which has been created, is totally under Dr. Fernandez's control. He has no time pressure within which he has to complete his investigations. last but not the least, he can test some virtual therapies on this model, observe the outcome, find out that some therapies may not lead to optimal outcomes, and then select the best therapy which is best suited for Hugo as a patient. And I'll make it a little more specific, and I'll go a little more detail into how such a thing can actually happen. So Dr. Fernandez now decides he's got a digital twin of the heart of Hugo, and he wants to kind of use it for planning the CRT therapy that he wants to do. So what he does is he takes the MR 3D images of the heart in the first step. In the second step, what he basically does is he superimposes or combines the anatomic information of Hugo's heart with the electrophysiological information which is coming from the 12-beat ECG. And he basically gets the baseline matrix and information like what you see out here, what is the QRS, and these are stuff which you basically see in the standard ECG procedure, which is basically done. Now he goes a step further and he says, okay, now I know the physiology and the anatomy of the heart, and now let me try placing the electrodes and programming them according to the different protocols which are available out there. So what he does is, just to simulate the first therapy, he takes these two small little electrodes which are there, places them on each side of the heart at a similar location. So the green dots, what you see in the video, are basically the electrodes. And then he basically decides to use the biventricular pacing protocol, which basically means as soon as there is any irregularity observed in the heart, you just fire, both the electrodes are fired at the same time. And what he sees is if he were to use this protocol, as you can see over here, these values, or red dots, basically show that this does not improve the situation. The target situation which he is targeting is all of these bubbles which you see out here end up becoming green. So he tried the biventricular pacing protocol virtually, and he realized that if he went with this protocol, Hugo will end up being one of those 50,000 out of the 150,000 patients for whom the outcome will not be optimal. So now what he does is he decides, okay, he leaves the electrode as they were placed. He does not change the position of the electrodes, but what he decides to do is use the left ventricular pacing protocol for the heart. So what it basically means is whenever there is a irregularity in the right ventricle of the heart, the left ventricle basically fires or triggers an electrical impulse, and then the heart is basically resynchronized. And the digital model basically shows him that if he uses this protocol, all the values are basically green, and this is better suited for Hugo than the biventricular pacing protocol if he had gone about. So just imagine, without having the patient cut open and at the table, before doing any of the procedures, Dr. Fernandez now knows out of the various options which are available to treat Hugo, which is the one he should go with. And there are other such examples of the bicuspid valve or the mitral valve as it is known. So you can get the information about the valve from the various imaging that you have. You can create a patient-specific biomechanical model of the valve, knowing the properties of the valve closure that is being created. You can say how much it contracts. One can simulate how the outcome will be if these personalized things were deployed, and then you can actually compare it with the real post-operative results. Similarly, we have some things which goes into the aortic valve therapy planning, where you basically see the anatomy of the aortic valve. You can do the model valve deployment because you know the properties of everything which goes in behind that. You can basically plan your intervention to see, okay, if when it expands, how would the iota look like, and things like that. And these are, just like I said, just a very quick handful examples of where digital twin technology, when applied in healthcare, can lead to phenomenally different outcomes, and it can be personalized for individuals. So, this is basically the last slide from my side. And I think William Gibson, when he said this, was bang on target when he said the future has already arrived. We are not talking about futuristic things out here. It's just not evenly distributed yet. So thank you for your attention. And I look forward to any questions or any other curiosity that you may have. Carlos, with that, I would hand it over to you.
Thank you, Saket. Thank you for your presentation. Hello, everyone. Thank you, Patricia, and also Health Cluster and the ITL for this invitation and opportunity. It's an honor for us. Also, I'd like to compliment all the invited speakers, and additionally, a special compliment to everyone who is following these spring webinars. I will just say some few words about the way Siemens Healthineers in Portugal works to foster innovation in healthcare, based on partnerships with the universities, with healthcare providers, and other relevant stakeholders. And we as a company believe that the best way to continuously push the boundaries of knowledge and promote health and well-being is mandatory for us to have partnership for goals achievements, because as you all know, no one can do this on its own, and especially in these days when we talk about technology and the interoperability topics and the grant access to the most people we can. We need to do this together, and we cannot do this on our own. And in Portugal, we have a scientific partnerships department that collaborate with universities, research and development organization, healthcare providers, and other stakeholders in the healthcare sector. And what we try to do is, in a simple way, is to grant access to technology. We work to promote clinical studies and also cooperate in masters and PhD programs. And the Technical University from Professor Monica is a good example of that. So we work with them in PhD and master programs, but we also have an agreement with Technical regarding magnetic resonance sequences development. And this specific example involves Technical University and healthcare provider and Siemens. So the same way that we do this in this specific case, we also try to do this in other stakeholders in our country, and always in this perspective of partnership and cooperation agreements. And beside that, I invite you all to challenge us and bring us your ideas, and let's see what we can do together. On the other hand, with healthcare providers and the other stakeholders in our healthcare sector, in joint collaboration models, we also work to develop and test new technology and new ways to deliver care. And here we are targeting not only research and development, but we aim to support and resolve some of the most relevant healthcare challenges today, like chronic diseases or diseases associated with oncology. And finally, focusing more on R&D in the research and development field. Although we don't have a R&D department in Portugal yet, we are now leading the Smart Health for All consortium. And we are doing this with the support of our global organization. And to talk a little bit about this specific project, that is a very relevant project for us. The Smart Health for All consortium is a 6 million euros project, partially funded, and is promoted by Health Cluster Portugal. And he has a strong technology development component focused on smart health, e-health, and ambient assisted living. And we aim to go beyond the research and development. We are also looking now to the translational part and to expand beyond national frontiers. And this specific consortium involves around 90 people working together from 24 different organizations that involves enterprises, but also R&D entities, and we work together aiming to improve people's lives. As a curiosity, Siemens as a company is here in Portugal for around 115 years. So we are here for a long time. And since then, a lot of innovation happened. And of course, the healthcare sector is no exception to this. And we as a company, we always have a strong focus on technology development. And specifically in healthcare, our aim is to expand precision medicine. And with that, we want to promote more and more individualized care, like you saw previously in my colleague presentation, and also aim to transform care delivery based on technology and digitalization. And with that, we think we can promote access to care, and also another important topic that is to support clinical decisions. And for that, we need to be strong and develop technologies like artificial intelligence, and also remote care management. And in the end, when we expand precision medicine and transform care delivery, we are improving patient experience and their outcomes. And we look at that, we need to look at that beyond the diagnosis and treatment. We need to look at that throughout the overall continuum of care, from health prevention, health promotion, disease prevention, of course, diagnosis and treatment, and go beyond and follow up. And so we are, I think we in the overall, we are very used to work in segmentation, but more and more we need to work together and get in the collect more broad information to work in the overall continuum of care. And as a conclusion, our ambition is to keep fostering innovation and leverage Portugal health ecosystem based on technology to address some of the current and also the future challenges, not only, of course, in our country, but also in a worldwide perspective. So once again, and to conclude, I invite you all to challenge us and feel free for that. So thank you for your attention and enjoy the session.
Thank you very much. Thank you both. Saket, with a very interesting kickoff of the topic, and Carlos a very insightful overview of Siemens Healthineers' involvement in the healthcare innovation ecosystem, namely in Portugal, and also a few challenges for the audience here. And I think it's a great segue for the next presentation. We already have a couple of questions from the audience. I ask for your patience, as we'll ask them in the end during the roundtable part of the session, but they're not forgotten. So we will now move to the next presentation of this afternoon. So this presentation will be by Professor Mónica Oliveira, who is a full professor in healthcare management science at Instituto Superior Técnico. She's also a researcher at the Center for Management Studies and a research collaborator of the Institute of Biomedical Science in the same institution. She coordinates Rede Saúde of the University of Lisbon, as well as the PhD program in Engineering and Management of Técnico, the Decision Science and Engineering group, and the Clinical Engineering specialization of the Masters in Biomedical Engineering at Técnico. Her research interests include the development of management science models to assist policy and decision makers in health and clinical settings, and she has several publications in international journals in these topics. She has been participating in international health projects, involved in advisory boards from the Portuguese Ministry of Health, and in general, she has a very broad field of applications in this field, and her background is in economics, and she has a PhD in operational research and health economics. So a very vast CV, and thank you so much for accepting this invitation, Professor Mónica, and the screen is yours.
Well, thank you very much for this very too kind introduction. And it's really a pleasure to be here. Thank you for the invitation. And also it's nice to have such a nice panel with people with whom we already collaborate, like JoinHealth. So I'm going to be a little bit provocative in this presentation, or I hope. So basically, many of you, I know that some people are from companies, some people are from working the interface between the industry and academia, but not all of you will know what is operational research. So operational research is an area that is not new. It emerged from the Second World War by the need of strategic planning and coordination of fleet from the naval area. And basically, operational research uses the mathematical sciences to improve health care management. So you may see that there is a lot of overlaps between operational research, management science, industrial engineering, operations management, but still operational research is one of those names for which it has associated several institutions. So operational research entails a large number of techniques: optimization, simulation, decision analysis, data analytics, problem structuring methods that are available, that have been developed in the last 70 years, quite much. And we know that these techniques are very much used in some areas. So you cannot see Formula One without knowing that there is a lot of optimization algorithms for setting times, the replacement of tires. You don't have good airports management if you don't have proper simulation tools, and also, for example, risk modeling in the oil industry. But still, when you look into what's going on in the health care management field, what you know is that still the use of such techniques is not still very extensive. And you may ask why? Well, when we look into the literature, what we know is that, first of all, not everybody knows about what is this simulation, optimization, these techniques, decision analysis included. We know that there is some required time for developing these models. It's difficult to have standardized approaches. There is some complexity in explaining these methods to people. Many of these methods sometimes are developed in a very normative way without the involvement of health stakeholders. And of course, we know that health is different than the other areas, and there are specificities that make more difficult the delivery of such processes. So what I should tell you is that the health management field, the health economics field has increasingly developed these techniques. So recently we have ISPOR, the Society for Medical Decision Making, using these in the healthcare arena, but still a lot of issues emerge related with the complexity of care, the multiple perspectives of people, that it's hard to measure value, and of course there are many other issues related with data. So what I want now to do after this introduction is to just give you some examples, practical examples on how operational research can improve healthcare management. These are real examples. Some led to implementation, not all, but still it's a little bit of an overview, so don't expect any specific insights. So my view of operational research is that we need very sound models with the good data, with algorithms. We need to involve people. When we speak about management, it's very difficult if we don't get stakeholders' involvement to capture their knowledge, to measure value according to their views. And of course, we need the technologies to enable that because, well, management, it's not the issue of using, for example, a new optimization model by itself, but you need to visualize what is behind that. So in my practice, all the cases I'm going to give you in trying to be a little bit provocative involve good design, a combination of the right methods, the right specifically fit group processes, and the adequate technologies. So first thing, what we know is that we see many hospitals, many healthcare providers that have a bunch of data, but still, which is the number of companies, providers that properly estimate their demand for care. So here is just an example developed with NOS and the Lusíadas Hospital, predicting the emergency entries. And well, this was just before the pandemic, but we could see that it's not difficult with objective data and with information from stakeholders, from the hospital, to build good models that predict with a nice level of accuracy the demand. So this can translate into better management. But how many of the institutions we know that use this type of models, less or more sophisticated? Very few, in fact. Second example, we live in a society of networks. We have supply chains, we have networks of hospital providers of primary care. But if we want to build networks in which we want to minimize cost, maximize equity, maximize efficiency, you need to use mathematical programming. But still, it's not that much used, despite of a huge literature showing that we can build nice models accounting for the demand, the characteristics of the supply. For example, here is an example of hospital referral networks, setting that given the population evolution for the future, given the type of care to be delivered in different types of hospitals and in primary care, where you should locate new hospitals for which populations. So if you consider that this is a need, you need to use mathematical programming models to tell you which is, for example, the type of network that give the minimum cost or the maximum access or a compromise between those. And well, this is an example for hospital networks, but I can give you an examples, for example, here of long-term care providers with different types of care, and to say, okay, how do we organize the network to maximize equity of access, socioeconomic equity and geographical equity, so that we know where we should locate to attain the different objectives. Of course, these are objectives from the public context, but we can do this for objectives from private companies. Another example, we speak a lot about now value-based healthcare, but still sometimes, well, of course, we know we want to maximize health outcomes. It's difficult to measure value in terms of health outcomes, but we have many other objectives. And we know in management that you cannot manage anything if you cannot measure. So even if it is very difficult, if you want to go through a paradigm in which you measure what is value, you need to use multi-criteria value modeling. That means that you need to do work, to define some type of mathematical model, but you need to engage your partners when you need to measure, so that you say which are the objectives to be attained. How do you convert these objectives into a set of criteria, and how do you measure, you use those criteria to measure value of, for example, health interventions. You have an example of that was developed several years ago with the group of healthcare centers of the North Lisbon for community care programs, to say, okay, we have multiple community care programs, we cannot go for all of them, we don't have nursing resources, so which ones provide highest value for money? So you need to consider what is value, in this case, effective health gains, equity, and other criteria. You measure value, you compute an overall measure of value, so that you have programs, you have overall benefit, you have the cost here in terms of nursing hours. And basically what you can do is to use tools. In this case, it's based also on mathematical programming, about which is the portfolio of healthcare programs that gives the highest value for the given resources. So, well, this is called portfolio decision analysis, also an area that we would think that would be increasingly used in health settings. But when we speak about value, well, we know we have problems. We have multiple stakeholders with different views. And we need to understand which are the views very often of all those different stakeholders. Here are examples of ongoing projects in the area of health technology assessment, in which we use, in this case, Web Delphi processes to capture what are the views of all the stakeholders, either by group of stakeholder or with a mixed panel, and we interact with them to capture their views, their knowledge, in which we incorporate in the models. So Web Delphi processes through new generation of models that are enhanced by computer technologies can be implemented and help us to, to engage people, take their views, their knowledge, and incorporate that is key to the modeling of models that are to be used in practice. So a last example before I finish my presentation. Some cases, until now, I was giving you examples of projects using mostly one technique, but here I will show you a more complex case that was developed with team from Carlos that has just presented. So it was a partnership with Siemens Healthineers, and it was developed, this work, in Hospital Espírito Santo. And the issue was about how to improve efficiency in the cath lab. And what we needed to do was first to understand how it worked, the cath lab, and also to understand what is efficiency, what is value for improvement. So we have built a multi-methodology. So very quick overview about the work that we have done. Not entering into details, we have a technical part that in which we have technical models, and as I've mentioned before, we always need to get the proper social interactions so that we have the models and we have the knowledge and the views. So for you to have a hint, we have developed further to workshops, decision conferences with people from every hospital, facilitated, making use of computer technology to consensualize what is value and what were the objectives of the lab and how to measure the attainment of those objectives. We have, of course, mapped the pathway processes. So in here, we have built simulation models that are, in a certain way, similar to what Saket has presented before. So these are discrete event simulation models. We map processes. We build simulation problem models that replicate what's going on in the lab, the entry of patients, the doctors working, the nurses working, and all those things. And based on that, what we could do, and of course, there was much more work than this, we could see how the system works, how the system can work if some managerial changes are implemented. So we have a simulation model. You see what's the impact in the model, in the cath lab in this case, of implementing different policies. And after, you can see which is the impact in terms of value of those policies, seeing that some policies are much more aligned with the attainment of value by the cath lab, as seen by its stakeholders. And of course, in this way, we could find and help, it's not us finding, we could help people from the cath lab finding and consensualizing which were the best improvement contributing to the objectives of the organization. So to conclude, and of course linking with a lot of what has been said by the previous panel members, I work in academia, and but in the paradigm in which we are, we need to work in networks. Of course, we need to have collaborative projects because we don't have in a single institution all the knowledge. And of course, here we need to have, on one side, to have research to develop these tools and to enhance their use in practical settings. Of course, having the scientific tools and the more applied interactions that people working in consultancy, working in providers have. And of course, parallel to this, if we want to have people using more simulation, optimization, and many other techniques, we need to work a little bit more on education so that we train and produce new professionals with a different type of knowledge than what we have been producing earlier. So thank you very much. And I hope to have a nice discussion afterwards.
Thank you. Thank you very much, Monica. So this was a very interesting presentation, and one of the things that I think it highlights is the crucial role of this collaborative work, and also the intersection of several areas of knowledge in order to implement solutions to improve healthcare, namely digital solutions in a successful manner. So I believe we'll have the chance to get back to this topic in the end. We'll now move to the last presentation of this session with Luís Patrão, the co-founder and head of partnerships at Uphill. Uphill is a medical training tool that supports healthcare professionals, but I leave the details for Luís' presentation, who will surely do it better than me. So about Luís, he's a specialist in internal medicine, and he's finishing his training in intensive care. He's passionate about medical education, simulation, and improving patient safety in healthcare institutions. So thank you very much, Luís, and the screen is yours.
Thank you for the invitation and for giving us the time to share what we are doing. Actually, and very interestingly, what I will say, I would say 60% of my time during the next minutes is very well related with what Monica has already been presenting. So words like pathways and simulation will be repeated during the next minutes, which I think it's very interesting, because she's working in an area that I knew that it existed, but I didn't have a proper name in my mind. So it's very interesting to be that things are so well related, and congratulations to the organization for being able to also to connect these dots between different stakeholders in this matter of digital health. So my main concern as a doctor is patient safety. So being involved in something different from my daily clinical practice would have to be something that would be innovative and that dealt really well with patient safety. So that's what we are doing for more than 6 years now. We were founded in Covilhã. We are a spin-off from the University of Beira Interior by 3 doctors, and now we have moved to Lisbon and throughout Europe, as I can show you here, just to give you an overview about what we are doing and where we are right now. So as you can see, you have as our clients and partners some of the key players in healthcare in Portugal and as well in Europe. So what we know is that no professional works at 100% of the time with 100% of his capacities and doing the perfect thing every time. So we know that in healthcare, this is a major concern, because as patients, we expect to go to hospitals and to primary care facilities and to be treated with the cutting edge of the science. And that's something that the system has in it. So we need to work on it, and that's what we are doing, because the literature is already reached about the differences between the compliance with guidelines and recommendations, and that relates in terms of patient outcomes. So of course that the better the compliance, the better the outcome, at least in a broader sense, and not talking in specifically in terms of any disease, but as a major issue in healthcare. We know that, we like to say that patients are in the center of healthcare. However, we know that sometimes we are far from that being true, and that's something that also we are working on. And how do we get there? We get there by helping doctors, nurses, and also institutions to complete this cycle in terms of monitoring and analyzing what's being done every day, providing some training and helping them pick the better training for what they are doing. And this obviously can give some feedback, and is a learning tool for the institution that then can change behaviors of those teams that are working with the patients. This, of course, deals with process, which is something that Monica has talked about already. We can give then some insights and keep some iteration, because sometimes what we as institutions, we consider ourselves institutions in terms of healthcare, what we think is the best for each team or each environment, it might not be that well. So that's why we need to build some pathways and to test them in simulated environments where patients don't suffer the bad outcomes of bad or not so well done pathways. So this is something that our cycle includes. This is just an example, thinking about any symptom that brings you to the emergency room, like headaches or abdominal pain or anything else. And you know that throughout the process of being treated, there are a lot of steps, and sometimes there are some deviations about what should have been done if healthcare professionals were 100% compliant, and what is really done, because sometimes of limitations in terms of teams or healthcares, or even in terms of what is planned for that specific situation. So what we know now is that if we work on that, we can improve compliance about these protocols, and then giving better outcomes, not only in terms of health, but also in terms of cost, because we are all paying for our health, independently if we are talking about a private or a public system. So this is also very, very important. So we have two major approaches about this in terms of, we work on simulation training, and what we do is to have a way that where we can test standardized clinical patients in a simulated way, so that we can then interact with these simulated patients based on pathways that were already done, of course based on international guidelines, but every time applied to that specific context in terms of country, region, or even the kind of patients that are treated there. And of course, this is based on clinical pathways or patient journeys, whether you like to call it, because we need to coordinate better, and also to when something changes in terms of the planning that we are doing in terms of those diseases and pathways, we need to update them quickly and to send those updates to all institutions that we are working with. So in terms of simulation and simulating simulating our patients in our clinical cases, what we have is an electronic health record simulated system where we, based on the pathways that I'll talk within a few minutes, based on that, we build clinical cases, and then we can then test and /train, of course, because things are related, healthcare professionals in terms of, this software is very tailored for doctors yet, about the course of action during patient management in the ER or in consultation. Of course, this gives a lot of information. It improves the compliance with the recommendations for that specific institution. But also, what we can give is some feedback, not only for the doctor, as you can see here, because in the end he knows immediately what has failed, what it needs to improve, and he might also add some disagreement with our proposed course of actions, which is very important for the institution then to know why he is disagreeing with the recommendations. But also for institutions, they can have a broader view and an immediate view about how that patient would be treated, because it's not a real patient, it's a simulated patient, would be treated by those doctors and by those teams, given that specific context, that specific town or that country, depends on the size and the scope of the institution. For patients, we we are already working in a patient's view of all our system, and that's why we are emphasizing this here. The patient then can have knowledge about what is expected in each case from the management and from blood analyses and CT scans that are done throughout that disease. This is very important because he can then detect and understand well, those that should be some deviations from some algorithms, and that's giving more information. It will improve suddenly these relations with institutions. Just to give you an example about some specific disease that we already work on, namely heart failure and COPD. We have, of course, training some doctors with this system. We have increased the compliance with the proposed algorithms, and of course, this needs to motivate the doctors to work with. So this is also a system that is desirable and satisfying for them. This is just an example of the dashboard that we can give the institutions that are working with us. So they have an idea about what is being done in terms of simulation and training, and also they can then automatically detect and target some gaps in terms of training, which is very interesting for them, because sometimes we have a broader idea and a generic idea about what our professionals need in terms of training, but when we have the evidence about that, it's very more interesting for being able to give them specific and tailored training. Of course, that we can give even more specific information about the exams that are being asked in any clinical case, and this is all based on pathways that we have in our system that we call routes, which is basically a way where you can have access to pathways, clinical pathways, based on the best evidence. This, of course, is something that needs a lot of scientific work from our side, because you need to keep evidence from, well, high quality evidence as a basis for these algorithms. And what we do is we put that evidence, we summarized it, and we build a generic pathway, clinical pathway, and sometimes operational, but the majority of the times it's 100% clinical related. We made that available in our website and also in our platform, so that doctors can have access as they are dealing with the patients in their daily clinical life. In the future, this will be related with electronic health records directly, so that we can improve the information about that specific disease or pathway. One of the different things that we do regarding clinical pathways is that we can version it. So if a new guideline recommends a new thing about a pathway that we already have done previously, we can change it and pass those changes to the institutions that we work with, and we can even adapt it in each institution to tailor the needs that they might have, because of course the institutions are very different throughout the world, and even within Europe and even in our country. So these pathways can relate with client journey management, for instance, in terms of relation with the front office and the check-in, and they can have a multi-actor interface, namely the doctor or the nurse and also the patient, which we will have in the near future. Just to give you an example about the phases that we see in our pathway development. So we start by developing, because we need to decide what is the best course of action for that hospital. Then, of course, we need to validate that between the real world data in that hospital and the teams and the disease that are there. And then, of course, relating this to simulate, start training and giving some feedback to the teams and to the institution. And then, of course, when we have these pathways more tailored after these previous steps, we then can distribute those pathways throughout the institutions. So this is what I wanted to share with you. I hope that you enjoyed our vision about patient safety and innovation. Thank you.
Thank you very much, Luis, for this presentation. I think we'll move now to the round table. We have already a couple of questions from the audience. Beta, I'm not sure if you will.
I am here. I have to leave in a while, but for the time being, I can stay and chat with you for a few minutes. So it's been a fruitful presentation and discussion of ideas. And there are a few questions from the audience, also from myself, because the scope is really interesting. And the first question that came up during the twins presentation was related to psychosomatic diseases. If there are already any relations of digital twins to this kind of diseases like chronic pain.
I think this question would be for Saket. I'm not sure if you can hear us.
We can, Patricia. I think, can you hear me all right?
Yes.
Yeah, great. So I think the question was about are there relations to digital twins to psychosomatic diseases like chronic pain, right? So I can answer this question only from the point of view of what we as Siemens Health Engineers are focusing on. And on that regard, this is something which is there on our roadmap, but is not something we have started working on right now, straight away. So we are going more along the pathway kind of, a scenario. So, psychosomatic diseases like chronic pain in a general sense is not something which we are working on currently. And on the broader side of, are there other partners that we are aware of who are working on this? I will have to, I can take this offline and follow up and get back, after having consulted my other colleagues who may have more knowledge on this than myself. So does that answer the question adequately?
I think so. There is also a few concerns about this new technology in terms of market, and I can join here one of my questions, which is what is the cost benefit analysis on the dollar or euro return on investment when we adopt this digital modeling technology? And I will also add not only this interest in understanding if there is really a return on investment, because this is for sure a huge investment for an institution to take on. But what is also the return, not money-wise, but in terms of risk benefit for the patient, for the users? What are your thoughts on this?
So on that one, so I think there are two parts to that question, right? So one is the financial aspect, and the other is more the health benefits and the for the patient as well, right? So I'll break that down into those two parts. Coming to the financial side, so I mean what I showed today is not yet available as a product out there in the market, right? So this is something that we have been collaborating with a lot of clinical partners, and we have got very positive feedback about the usage of it in the studies that we have done with our clinical partners in the US, as well as our other clinical partners out here in Europe. So we see that this having to do something like this is definitely a financially viable endeavor for not only for our customers but also for us. So there is some element of that cost financial planning which has gone in behind that. I would not be able to reveal more about it because of the confidentiality associated with it, but definitely there is definitely an attractive piece out there. Coming to the point of benefit of risk versus risk versus benefit for the individual patients. As per the studies that we have done, we see, so I mean, what we have done is also kind of, we have monitored real live surgeries, and we've basically run this model and seen, okay, what did the doctor decide without the model, and how did the model basically recommend what could be done. And we saw a very, very close correlation between what was being done, what was being performed, and what the model was benefiting. The final jury of whether this really improves it for the patient will come back to I mean, I would leave that to be responded by the medical experts out there, because let's face it, it's a what if analysis, right? So I mean, based on the information and the data which is available, and these are exactly the data and information based on which decisions are taken today, we definitely are ruling out in the clinical studies the treatment options which would have led to suboptimal outcomes. And if I look at it from a patient point of view, it means having to undergo unnecessary procedures and unnecessary pain. So in that sense, the answer to that second part of your question would be yes. But that's, of course, us based on our studies, the clinical studies that we have done. Time will tell us, and I think I would go more with the clinician's verdict on it rather than somebody like us telling it.
We cannot hear you, Vera. You are with your microphone muted.
Yes, sorry. And also regarding these endeavors that you are doing at Siemens, do you include integrative medicine? There was a question from the audience, is very specific, but in your projects, do you include this kind of medicine?
So we do kind of I would say the answer to that is broadly yes. So we do kind of have, like I think Carlos also mentioned about this, about follow-up, remote patient monitoring, and having also questionnaires and getting answers like based on the social detriments of health, so to say. We do kind of add in other elements of data like the genomics, the molecular diagnostics, and so on and so forth. So I would say yes, we do. We are definitely going into that direction. There is also an offering of ours, which is basically called, the AI Pathway Companion, which is basically going exactly in that direction.
And this could be, this next question could also be shared with the other panelists. Do you believe, in each and everyone's opinion, that the European regulatory landscape for medical devices, for artificial intelligence, it stifles innovation in digital health in the European Union? Can the European Union lead in this field, or are we still behind other regions like the United States, China? What is your opinion? Are we moving forward, or are we lagging behind?
Well, I can make a start to that question, even if maybe I'm not the right person. Well, the good news is that we have some type of consciousness that there is a need to a strategy and to put money on that. Personally, I think that the portfolio of initiatives and projects in digital area is not very balanced. So the way the priorities are set for the European Union to help is quite unbalanced. For me, that I work in decision science, I see things about we need data, we need to convert data into knowledge, into information into knowledge, and afterwards to go to decisions. And if we see all this cycle, we see a lot of money being put in data in part and not in all areas for better decision making. So that is one of my perspectives. The other thing that relates to the previous question placed by Saket is that health technology assessment is still a very incipient field. It's very developed for medicines, but not for medical devices and not for other areas. Of course, we know if the private companies put money, it's because they have a return, even if they may not publish cost-benefit analysis on those terms. But we have evidence from the OECD and from several reports in which not always these investments in digitalization in all the areas, they accomplish the value they should. And you have really a lack of culture in showing the added value in several areas. So it's much more about you believe, you say, you show some sparse evidence, but there is not a culture of showing with health technology assessment that this technology added on this, that, and that on a systematic basis.
I will follow on this discussion as Vera will have to leave soon. So there is another question. I think it goes along this one about data and data sharing. That probably has to do also with this fear or hesitancy of people to share their data because they cannot see this, as you were saying, this benefit of the solutions that may arise from here. And also adding up to this, you Monica, you mentioned some resistance of the sector itself to implement some of these methodologies. You named some of these factors. And of course, I would say there are some specificities of the health sector that make it so specially resistant or difficult to implement some of these methodologies and some of these processes. Do you want to comment on this based on what you were saying about the people being not so confident, and it is a two-sided question, you know? It's on one hand, people are not implementing this because the field is very regulated and probably they cannot see why they should be implementing these methods and they do not recognize the value. And on the other hand, if we cannot measure it and if we cannot implement these processes, we will not be able, as you were saying, to understand the value of implementing this kind of processes. So how can we go beyond this and actually start making this reality in the healthcare sector?
Well, regarding this point, I think that it's about culture and training. Mm-hmm. And I would say my initial background is in economics. And you have many people from economics and management working. For example, you study a lot of statistical methods. You don't study optimization. So you don't have that much. And even like Luis was showing about simulation, you have discrete event simulation, agent-based model, you have many types of simulation techniques, but still, even people in the area of management, they are not trained, they don't have knowledge on many of these tools. That's why we see some societies, as I've mentioned, HISPOR, Society for Medical Decision Making, saying that, come on, to answer to these questions, we have those techniques. We need to learn with them. We need, of course, some of those techniques. It's different if we are managing Auto Europa because you don't have such uncertainty. You have standardized processes. It's not what works in healthcare, but still, well, from the industrial domain, they do it. Coming to the health sector domain, some private companies do, but you need training, you need to change culture. And of course, it requires some investment. But you see that in some areas. Let me give you an example of the operating room. All hospitals know that operating room is a large area. You put money. If you don't optimize, you put money to the bin. But still, and you have many algorithms emerging and many technical solutions, but still the adoption is relatively low. People do not know, or the change has some costs or other stuff. But maybe here, Siemens, people working, I'm an academic, right? I create methodologies, with partners, but I'm not so much on the implementation side. So some people like Carlos, for example, and also Luis, must have more clear views about the challenges of, doing this bit of this translational bridge.
I think the beauty of it is actually this collaborative work and the fact that academia can be close to the companies and to the sector. I'm not sure if Carlos wants to add anything to this question.
Yes, so I partially agree with Professor Monica, because I think also there is a strong cultural issue here. So we, in a healthcare sector, we are used to do the things one way, and we are not very keen to change the way that we work. And our experience is that, of course, there is this real challenge and this difficult, but at some point when we are able to measure and we are able to show that there is an increase if that is possible, I'm sorry, to optimize and to reduce costs and eventually provide better care, and also the staff will be more happy because they will do better their job. We have some opportunities here, and so it's a struggle. It's difficult, but I think more and more we will talk about this. And regarding the overall perspective, I think that these things, usually the change takes time in all the sectors, and specifically in the healthcare sector, it takes a little more time than usual. But at some point, things will start to change, and we will see some examples, some pilot examples, and if we start to disseminate these overall and these critical perspectives, these new ways of working, at some point we will start to disseminate the knowledge. But I agree that it takes a while. Also, I think other hurdle regarding this are the topics related with cybersecurity, and also the RGPD. So this came up recently, and we are not yet totally looking at this and how will we manage this. And we talk a lot about data, but we need to use this data. We need a clear framework. We need to structure this data. This data must be accessible to the right purposes. And so I think we are not. It will take some time for us to adopt all of this. But I believe that in the future, this will be more easier, and we will be able to implement all these solutions and all these optimization processes.
Thank you. So, Luis, now to you. So, I think you ended up integrating some of the concepts that both Saket, Carlos, and Monica approached during their interventions of simulation, digital twins, modeling, and the processes, which are also relevant for the decision-making processes within healthcare institutions. And during your presentation, you talked about the need to tailor the solution, to be flexible, to adapt. So my first question, which is related to one of the questions from the audience, and I will try to merge them both. How does a young company like yours prepares to respond to this ever-changing and though very, very regulated environment that is the one of healthcare? This is the first challenge for you. And the question from the audience, as I was saying, is somehow related to this one. If there are other competing companies responding to this market need, and how yours differentiates from those competitive companies.
Yeah, thank you. So I will start by answering the last one, which is obviously, yes, there are a lot of competitors. However, and this leads to the first question and to what was being discussed previously. It all has to do with the approach that we do to this problem that we all know that happens. And Monica talked about the operating rooms. We can talk about emergency rooms. We can talk about a lot of things. Waiting lines, queuing of the patients. We can think about a lot of things that we know that are working bad in hospitals and primary care facilities for ages. And we have have yet the difficulty to solve them. And this is not a technological problem, and it's a process problem, and it's a culture thing that has already been said. But sometimes we talk about the culture, and when we say, well, and we assume there is nothing that we can do to change it. And our approach is exactly about that. So when we do things like training the professionals in certain areas, they are being trained, and we can make them think that that's all about the training, and they are all in learning in that I would say 30-minute session. But we are not only training them, we are doing much more than that. We are gathering information about how they would behave in a real world situation, how they will interact with that patient, what exams would be asked, what references they would do to other colleagues, for instance, or to other professionals that work in the hospital, let's say about the diet, for instance, or some patient that needs to go to the physiotherapist, for instance. So this interaction in this human factor side of the things, of all of these things, it's what is really important. So we are using technology to work on that. Of course, that we cannot put a sign on the door saying this, you will now train human factors, because no one would enter that room. But we can give something that the professionals did, which is training. And in healthcare, all professionals know that and want the most training they can get hands-on, and using that we can use the psychological side of things, and help them be better professionals in the future. This is something that, for instance, it relates a lot with high fidelity simulation. For instance, I've worked some years in high fidelity simulation, and which has those fancy and expensive simulators that resemble a live patient. And we used to say in high fidelity simulation that it's not about the technology, it's about creating a scenery and creating a context. And of course that those simulators help a lot, but they are not the only thing that needs to be worked on in those sessions. You have to put things in context. People need to be comfortable about the role they will play, as people need to be comfortable when they go to the computer and do some training, or they can check our pathway. So the user interface, everything about human factors needs to be worked on. And this is just an example about how differently we are doing things in order to achieve our goals of improving patient outcomes. I hope I could add something of value to the discussion.
So thank you very much. You certainly did, and actually you ended up also answering one of the questions from the audience, and the last one, by the way, about the challenges for that will, or the institutions will face for practitioners to use digital health, and again, some of the points you mentioned also went through this. So I think we'll have to close this session now. Thank you very much for your insightful thoughts and for sharing your experience. So this is clearly an ongoing conversation, and there are a lot of things that are adding up to the complexity, but also to the opportunities that are on the healthcare sector in this field, and to implement in a better way digital health solutions. But before we close the webinar, I would like that, in fact, we'll also close this webinar series. I would like to thank once again the speakers and also the attendees. And I hope this has been an interesting session for everyone. Before we close this webinar series, and as a roundup of the series, just to let you know that this is the 8th webinar of this season. We have had more than 20 speakers and 400 live attendees in total in this series of webinars. And I invite you all to stay tuned with the updates about the upcoming webinar series next autumn by going to healthportugal.com or through the Health Cluster Portugal's or EIT Health social networks, as we'll be preparing this next season with very exciting new topics and speakers. So it has been a pleasure to host you through this series, and we'll keep in touch. Thank you very much and see you soon.
Thank you. It was a pleasure. Bye-bye.
Thank you.
Bye, thank you.
Thank you all. Bye-bye.